So chapter 27, last chapter was on soft tissue damage, and so this is the chest and abdominal trauma, and some things we're going to cover with is pneumothorax primarily and some abdominal issues. So when it comes to chest, when you can just picture your chest, everything behind it, is really your lungs and your heart, and so the damage that you're going to see are going to affect those areas. So you got blunt trauma, which can fracture ribs, sternum, and costal cartilages, which is the ribs between the ribs. So your rib, that could be a baseball bat to the chest, a steering wheel to the chest, a fall down some stairs. Anything that really is a blunt trauma is not it's not a penetration. It's just a force that can hit and cause those damages. So if you fracture your ribs and your sternum and your costal cartilages, everything behind that is at risk. Compression occurs when severe blunt trauma causes the chest to rapidly compress. Again, that's the fall. Primarily that's a car accident from what I've seen the most of. But any kind of accident, a motorcycle accident, falling off your bike onto a curb, you guys can use your imagination and figure those things out. But a penetrating object, that's the like I said, the puncture wound. And so when you do your reports after a call, you have to actually list the mechanism of injury. Is it blunt? Is it penetration? So you're gonna have to be specific with these things. So this is your bullet, your knife, shrapnel from metal or glass, pipes, other objects like that. So they can damage the same area and internal organs that are behind those areas. So a closed chest injury, which if you guys remember from the previous chapter, a closed injury is there's no pathway from the outside to the source of that. So the skin, the muscle, all that's still intact. So this is where you can break your ribs, and flail chest is what you would see. You're not going to see your way into the injury, but you'll see the injury from the consequence of the injury, which is a flail chest. And that's where two or more ribs in two or more places are broken. So if you look at that picture, you got a break and a break, and then down to the next rib, a break and a break. Well, even if you just had two ribs that are broke twice like that, that's a flail chest, two or more places. So as you can see, that's a big issue right there in that area. So closed chest injuries, just remember, so the flail chest will work backwards. So when you're using your inspiration, your chest expands, the flail chest goes inward because the pressure is changing. So again, when you exhale, right, your lungs expand, your rib cage expands, your lungs expand, all that air goes in, gas exchange is done, then you exhale, and the good O2 leaves, right, and you breathe off your carbon dioxide and all that good stuff. So when that happens, when you exhale, the pressure changes, so the flail chest will go in, and then when you breathe out, the flail chest will go out. So it's the opposite of the movement of your actual rib cage. Fracture of two more consecutive ribs in two or more places, we just said. So the paradoxal motion movement of the flail chest is the opposite. So like we just covered with that picture. So just remember that when you walk up, you see them exhale or inhale, the flail chest will go in, exhale, the rib cage will contract or constrict, and the ribs will go out. Mechanism, when you're doing your assessment, find out the MOI, capable of causing the injury, steering wheel, bike accident, what is it that caused it? Check their breathing. Are they having difficulty breathing? Are they hypoxic? Pain at the injury site. Likely signs of shock and hypoxia is what you're probably going to see because they're not able to get good perfusion. They're not breathing adequately. Chest wall muscle contraction. Like we said, the flail chest. These guys are going to probably end up being hypoxic and struggling to breathe, and because of this issue. When you do your primary assessment, head to toe, right? Rapid head to toe. Check the head, check the face, check the JVD, check for throat, the throat, and then also treat any life threats. So you want to administer oxygen because they're probably going to be going hypoxic if they're not already hypoxic. If the patient is breathing inadequately, assist ventilations. So start with the non-rebreather at full 100% oxygen, 15 liters. But then from there, the next backup plan, if they're not adequately breathing, you're going to probably have to assist their ventilations. Follow local protocols that we will use, which we're going to teach you after you pass your registry, regarding non-invasive positive pressure ventilation. So this is, you know, CPAP and that kind of stuff. Monitor patient carefully. Be looking at them, watching for changes, because that flail chest, if they're not already having a pneumothorax, they potentially could be getting one pretty, at any moment. So be watching for changes in their status. Again, anytime there's an oxygen issue, there's a potential for a neurological issue down the road if things go south. So be watching just constantly reassessing this patient. This is one of those every 5 minutes reassess. Watch respiratory rate and depth. Are they getting good ventilation? Are the respiratory rate, is it tachy or is it Brady? Be watching for where they're at with that. If they're in normal range, great. Watch, make sure they stay there, and make sure they're getting good ventilation, not just by the pulse ox, because pulse ox will tell you that they're perfusing okay, but make sure to be watching for good ventilation. Watch their inhale and exhale. Are they getting good tidal volume? Open chest injuries, they're difficult to tell what is injured from entrance wound. So depending on what you see, you don't know what's going on behind there. So assume all wounds are life-threatening. When you walk up on a patient and they got an open chest wound, instantly life threat. Your lungs, your heart, all that's behind those rib cages. So make sure to be treating it as such. Now, the thing with the chest wound is it allows air into chest, and that will set like it says here, set some balance and pressure. So you got to look at your chest is like a cockpit to an airplane. You get a hole in that cockpit, the pressure changes. Same goes for the chest. Bad air will go in, good air can't get out. It's going to change that pressure, and eventually those lungs will collapse because of that pressure change. So a sucking chest wound, which we've talked quite a bit about, I believe, you're going to have to watch for that. When you may not always see a sucking wound, but chest cavity is open to the atmosphere. So there may or may not be sucking sound, and there may be gasping for air. Chances are they're probably going to be gasping for air because that pressure changes. Those lungs can't fully expand and do its job. So it's really amazing how God designed our bodies, because our bodies are designed so brilliantly, but at the same time, any imbalance to the way we're designed can cause us a downward spiral. So we have pressure in our chest when we inhale and we exhale, and it's perfect. But man, you put a hole in that chest, the perfection is no longer there at this moment, and that pressure changes, and it's going to change our dynamics. Our lungs will collapse. We can't breathe properly. We're going to be gasping for air. So you want to treat that. That's a life threat. Stop the bleeding. Control the bleeding. Put a three-sided bandage on that thing, and make sure to watch for changes. So right here, maintain open airway. Keep that airway patent. You seal that wound. Apply occlusive dressing. Administer a high concentration of oxygen. And then we're going to care for shock with immediate transport. And we're going to have a chopper already meeting us at the hospital. So involving the tape and dressing with this, occlusive and the flutter valve, place and leave a side or corner of dressing unsealed to let that air get out. As patient inhales, the dressing will seal the wound, so bad air won't be able to get in. As the patient exhales, free corner of or the edge acts as a flutter valve to release air trapped in chest cavity. So it's brilliant. You breathe in, it seals itself, and no air in the atmosphere can get in. When you breathe out, it's going to go out that trap door and allow all that air to escape that needs to escape, and try to help that pressure. Perfect. There's a good example. So when you're doing these things, does the patient's chest injury need to be treated during the primary assessment? Yes. It's a life threat. Does the open chest injury require an exclusive dressing? Yes. Does the patient injury necessitate immediate transport to a trauma center? Yes. Those are actually kind of dumb questions, but injuries within the chest cavity. So you got the pneumothorax and the pneumothorax. But anyway, so you got the pneumothorax, and you got a hemothorax and a hemopneumothorax, and a traumatic asphyxia, cardiac tamponade, and aortic injury and dissection. These are things that you're going to see on a chest injury. So just remember these names: pneumothorax, hemothorax, and the hemopneumothorax, traumatic asphyxia, cardiac tamponade, aortic injury, and dissection. So with that said, the pneumothorax and tension pneumothorax, the pneumothorax is when air enters the chest cavity. So you got that hole in the chest, Atmospheric air can get into that chest, change the pressure, and it will possibly collapse a lung. Then the tension pneumothorax is a type of pneumothorax where air that enters the chest cavity is prevented from escaping. So again, it's going to cause the same problem. A tension pneumothorax and pneumothorax is similar things, but you got to realize the air can't get out, it's going to cause the same problem as a normal pneumothorax from a trauma. So here's a picture. You see the chest wall. You see the air that gets in there. The pressure builds up and it collapses that lung. So when you listen to the four lobes, you're going to, on one side, hear perfect breathing, potentially perfect breathing. On their side, it'll just be absent because it's collapsed. But you're going to be able to tell by their response that that lung is collapsed. And so that's going to be a tough deal because what that is they're going to be gasping, they're going to be struggling, and you're going to know when that happens. A pneumothorax, tension pneumothorax, patients typically have diminished or absent lung sounds on affected site, so you won't be able to hear it. Hemothorax and a hemopneumothorax is a hemothorax, chest cavity fills with blood. Same concept as air, but now it's blood, internal bleeding building up in that airway or in that area. And so the same thing, that pressure from that blood, when that lung can't expand, it's going to collapse. A hemopneumothorax, chest cavity fills with both blood and air. So just really important to understand, just like we practiced the registry last week, same kind of concept, guys, is recognize words and break it down. So hemothorax, hemo is blood, thorax is thoracic. Hemopneumothorax is blood and air and the thoracic. So keep that in mind. And there you go, is a picture. You got air building up around, collapses the lung for the pneumothorax. Hemothorax is blood builds around, collapses that lung. Blood in the hemopneumothorax, the blood in both air build up and collapse that lung. So a traumatic asphyxia, sudden compression of chest forcing blood out of organs and rupturing blood vessels. Bad deal. So neck and face are darker. So when you see these, they're going to be so damaged. A lot of blood's going to be shunted. It's going to be dark color. It may cause bulging eyes, distended neck, veins, broken vessels in face, and not a pretty sight. Cardiac tamponade, so direct injury to the heart, causing blood to flow into the pericardial sac around the heart. So that pericardial sac, as we discussed, is pretty thick. I mean, it's not thick. It's pretty strong. It's made not to be broken. So when the blood in the heart's bleeding, and now it's building up into that pericardial sac and causing a cardiac tamponade. So the pericardium is a tough sac, rarely leaks, so increased pressure on the heart. Chambers can't fill, fills up that sac, and it's a bad day. Cardiac tamponade, blood backs up into the veins, usually a result of penetrating trauma, distended neck veins, or shock and narrow pulse pressure. So I want you to look at this for a second. So let's look at penetrating trauma. You get a pipe or a knife to the heart, so right to the left side, right through the rib cage into the heart. That heart is an organ. It's going to bleed, and that blood pressure is going to build, or that blood's going to build up in that pericardial sac and not be able to escape because it's designed to be pretty darn strong. And now the heart, same as lungs, the lungs can't expand with pressure. The heart can't beat. It's trying to beat and fill those chambers. Now blood flow can't get in those chambers, which is causing a tamponade. And so the blood is building there and not being able to pump properly and get to the body properly. Everything's bad at that point. So what that said is it's going to distend, it's going to fill back up into the veins. The blood's not, because it can't flow properly, and it's going to build up. You're going to see a distended neck vein. So that's the JVD you look for. And when you're listening, you're going to see signs of shock in the vitals and the blood and the narrowed pulse pressure because it can't build. It's tamponade. It's cardiac tamponade. So an aortic injury and dissection. An aorta is the largest blood vessel in the body. So again, picture where the aorta is in your heart. It goes down the back. Penetrating trauma can cause direct damage. Blunt trauma can sever or tear the aorta. Damage can cause high pressure, bleeding, often fatal. So, I mean, once they got the aorta dissection, that is a bad day for that person. So that's ALS is definitely going to meet us at the hospital. We're going to do everything we can, but it's going to be a pretty rough day. So I just want you guys to understand the aortic injury and dissection. So you got to understand the aorta is packed with oxygenated blood. And so if that gets dissected from an accident, a tear, whatever, it's basically a pretty fatal hemorrhage that's going to be taking place. So read that chapter pretty good. Read that in your chapter pretty good, and understand cardiac tamponade and the aortic dissection. So patient complains of chest and or pain in the chest, and abdomen or back. So 3 locations that they could feel pain. Why? Depending where that tear could be. For one, because it goes right down that area. So pain could start in the chest, it could be in the abdomen, it could be or in the back. The problem with these things is sometimes they don't know what happened. It could be a medical issue, and you don't know what happened, but they're complaining of back pain, but you're not necessarily thinking cardiac because of the back pain on a medical call, and so you may miss that. But when it comes to a traumatic injury, it's on your radar. So just be paying attention when people say back pain, chest pain, or abdomen. You're going to see signs of shock, right? Because they're going to be a hemorrhage. So an hemorrhage will cause that blood pressure not to be good and tachycardic and possibly a high respiratory rate. Differences in pulse or blood pressure between right and left arm. So your right arm, you might get a higher blood pressure than you might on the left. So you got to watch for those things. So check for those things. You know, we don't always think about let's check blood pressure on both sides of the body, on both arms, but do that some from time to time, and you're going to see them, see the differences. So commotio cordis, it's uncommon condition. This is within the chest. Trauma to the chest heart is vulnerable. So if untreated, patient will go into VFib, treat like VFib, get ready for CPR and defibrillation. So there's a lot of things that could cause the heart to be, you know, some people, like, for example, they just have an enlarged heart. Well, an enlarged heart, and then they get in a chest trauma, and their heart can't respond properly, and it may get into VFib. So this is uncommon, like this chapter says, commotio cordis, uncommon condition. But when the heart is already vulnerable, you get chest trauma. I mean, let's imagine this. Maybe they have an electrical problem, and I say no, they have a problem with their electrical system of their heart, and then also they get an accident, and it's going to kick that heart into VFib. Because sometimes people go into VFib just for the simple fact their heart electrical system is already malfunctioning. Maybe they're on the pacemaker. Maybe they're on a pacemaker and they get a traumatic injury, and that pacemaker can't function properly. Then go to VFib. So there's a lot to this. I don't understand commotio cordis a whole lot, so please read this section very thoroughly in your chapter. But I do understand VFib and VTAC, and a lot of times VFib is not a fast heartbeat, it's just a scattered heartbeat because the electrical system gets damaged, or they're already compromised, and then they get a traumatic injury, it can just kick that into gear. So if you suspect anything like this, get ready. Have the AED hooked up, get ready for a defib, and be ready for CPR. So when it comes to abdominal injuries, these can, the same as the chest, can be open or closed. Internal bleeding can be severe if organs or blood vessels are lacerated or ruptured. So internal bleeding can be severe if these organs are lacerated or ruptured. Serious painful reactions if hollow organs rupture. So an example is hollow organs full of stuff, chemicals, stuff your body needs, except for the toxins that's maybe trying to filter out. But when those hollow organs rupture, now it's spread through the body. At the same time, it's going to be a lot more pain to a hollow organ than a solid organ, because a solid organ, by its definition, is solid. So always be watching for their pain level when they have an abdominal issue, and be open to the possible rupture. So evisceration may occur, organs protruding through wound openings. So if there's a hole in the abdomen, very good chance that some organs are going to start to leak out that hole. Like this guy, see that intestine protruding out of that damage. So first, take your standard precautions. Glove up, goggles up, possible mask, and then secure the covering with tape or with tape or cravats tied above and below the position of the exposed organ. So you want to stop the bleeding, and one way you can do it is you can cover the wound, but you can also treat it like a stab wound, right, or a penetration. You're not going to just pull that tool out. You're going to put some 4x4s or some Kerlix roll, whatever you can, to stop the bleeding around that site, and then throw some wet dressing over that wound and tape it. But you don't want to move the organ. You don't want to touch the organ. You don't want to play with it. That's for sure. So you want to be delicate with how you take care of it. There's that one we saw the other day in class. Pretty crazy. It looks like, if I'm thinking right, you can even see the pericardium that's supposed to protect that. So patient assessment, pain initially mild, but rapidly becoming intolerable. Typical with any kind of big major injury. They're going to suffer from cramps, nausea, weakness, thirst, obvious lacerations or puncture wounds to the abdomen. So, look at those signs and symptoms, because it is funny. Thirst, because they're dehydrating, because they're probably bleeding a lot. Your body, it needs its fluid to survive. So when you have that kind of damage, your body wants that fluid to help it survive. Lacerations and puncture wounds to the pelvis and middle and lower back. Check, basically when it comes to head to toe, you're going to check every area. Indications of blunt trauma. You're going to look for indications of developing shock. What's those vital signs doing? Coughing up or vomiting blood. Because, again, these are things that you're not going to necessarily see. You got to look at the symptoms to see what's going on inside the body. Rigid and or tender abdomen. Distended abdomen, because there's a lot of blood going on. There's a ruptured organ maybe. There's something happening inside that's causing fluid buildup. Patients tries to lie very still. So again, when you're going through assessment, you may not just walk up and see that, So look at how they're feeling, and then go through the head to toe assessment and look for the lacerations, indications of trauma, indications of developing shock. Read the vitals as you're doing this. If they're coughing out blood, that's a bad sign. Obviously, something inside is ruptured or hemorrhage potential. Rigid or tender abdomen, distended, and how are they behaving? Are they trying to be still or not? So just take a look at all those things. Stay alert for vomiting. Keep airway open. So anytime you got vomiting starting, get that suction ready and be managing that airway. Place patient on back with legs flexed and knees to reduce tension on abdominal muscles. Sometimes when they're just in the fetal position, that helps those muscles relax, not stretch or contract. Administer high concentration of oxygen and then treat them for shock and move on. This is where you don't want to give nothing by mouth. So most medications that you would give on this ride to the hospital would be via IV. Zofran, not by mouth, but by IV. Keep watching those vital signs every 5 minutes. Transport as soon as possible. A couple things when it goes to moving on is control external bleeding and dress all wounds. So that's not rocket science. You're doing your head-to-toe assessment. You see bleeding, you're going to control it. Do not touch or replace eviscerated organs. You're not going to try to pull the organs out. You're not going to try to put them back. Just apply that sterile dressing that's moist around that organ and wound site and transport. Additional steps, that you're going to do too is for large wounds, you're going to maintain warmth by placing layers of bulky dressing over exclusive dressing. So again, you're going to maintain warmth by not leaving one dressing on. You're going to put more dressing over the dressings and keep them going, keep that wound warm. Do not remove any impaled objects. Obviously, we've talked about that before. The only area that you would potentially move an object is, well, there's two actually. One is if you're going to do CPR and the stab is in the chest, or the object is in the chest, or in the cheek, that is an airway problem. Remember the facial wound. If it's in the cheek, it's caused an airway problem. Some things you want to keep doing is stabilize with bulky dressing, bandage in place, leave patient's legs in position found to avoid leave patient's legs in position found to avoid muscular movement that may move impaled object. So why is the legs important to the abdomen? Because it all connects. So if there's a wound in the abdomen and there's an object there, you want to keep the legs in the place because, all you guys know when you walk, you stretch your legs, you stretch that abdomen, and it could be an issue. So hope that helped, guys. Take a look at the chapter pretty thoroughly. And send me any questions that you might have, okay? So hopefully this is good. I mean, it's only 58 slides, so it's a pretty quick go through. But if you guys need anything with questions, text me. Read these questions. They will be on the test, and we'll talk to you guys soon.